have a quorum, so we're going to start public testimony on House File 1233. And I'm calling the meeting to order first, I was told, I must say. And we have a lot of people signed up to talk today. We're going to go
Holy moly.
till 11:30, come back at 7, and try to get as much done. We will also have a smaller amount of testimony tomorrow, but we only have the regular time slot tomorrow. We cannot do it tomorrow, so we need to get as much done as we can today in terms of letting people testify about the bill. And we're going to start with John Barker from Mendaca. Be here.
But I might just if they take some of our recommendations.
And we're going to try to hold everybody to 3 minutes of testimony, and then, but we will still have a little bit of time for questions for each individual. So, Mr. Barker, welcome to the committee.
Not a problem. I'm going to get on the road before the weather gets bad here today. Good morning. My name is John Wayne Barker. I'm the Executive Director of Merrick Inc., a DT&H program in Vadnais Heights. Here today representing Mendaca, a trade association representing DT&Hs throughout the state of Minnesota. I want to thank the chair and the committee for including the repeal of the 1.67% rate cut that was scheduled for July 1st of this year, and for a 2% COLA. In the last 10 years, as a nonprofit, our spending has been reduced by 26%. And since 2008, we've taken a 5% rate cut as the state struggled with its budget deficits. This has resulted in a chilling effect on our ability to provide livable wages to our most valuable asset, the employees of our nonprofits. And your support of these two provisions is truly appreciated. Besides feeling good about improving livable wages for our direct care staff, it also makes good economic sense, as demonstrated by our case study, which showed a 3-to-1 return on investment for all state dollars invested in programs like Merrick. And I've got a handout here that someone can share with the committee members when it's convenient that summarizes that study that was completed by an economist at the University of Minnesota, Dr. Ford Runge. Finally, we are still working with DHS on two important measures that this committee will hear in the next few days. One is the rate framework, and the other is the licensing rule, and specifically the licensing fees. The rate framework has been a project that's been worked on since 2009, and we're hoping that a coalition of providers and DHS are finishing up with some technical amendments that both groups can support and bring to your committee for review yet this week that will help transition us from today's reimbursement system to one that satisfies CMS, the state, and the stakeholders. And so we're hoping that that happens, as well as licensing fees, which are particularly onerous to day programs, in that, as proposed, would raise our licensing fees from $5,000 a year to $20,000 a year, a 400% increase in over 10 years, $150,000 diversion of funding for clients and mission to licensing fees. And so, again, we're hoping that those two items can be successfully agreed upon and brought back to this committee, and we look for your thoughtful support of the issues and concerns we have as providers on those 2 points. That's it. Was here really to thank you for the things you've already done on our behalf, and I can answer any questions.
Well, Mr. Barker, just on the, if there is an agreement, we're running out of time to get it done. But next week we will have Ways and Means, and we'll also have an opportunity probably on the House floor, if there's an agreement that both the department and your organization's support. We'll try to get it in, but we're running out of time for Friday.
Yep, I think they're working on it to take some action yet today.
Okay, any questions for Mr. Barker? Thank you very much for your testimony. Next is Ann Henry from Minnesota Disability Law Center. Welcome to the committee.
Thank you,
Ann,
Mr. Chair and members. My name is Ann Henry, and I'm with the Minnesota Disability Law Center at Legal Aid. I'd like to mention just 4 areas that we are strongly in support of, and then raise 4 problems or issues. First, we are in strong support of a lot of the mental health changes that are included here. We think they will help many of our clients with mental illnesses, many of whom also have other physical or developmental disabilities. We are also in support of the governor's proposal for autism spectrum disorder funding. That is extremely important. We have been working with the department and other interested people on an amendment to make the language work better, and hopefully we will get the no-cost blessing so that it can be considered by the committee Friday. Representative Norton is carrying on her young woman's work on autism. Third, we certainly support the community service rate increases that you just heard about from Mr. Barker. And fourth, we support the changes to transition people out of St. Peter and Anoka. That absolutely needs to be done. On the problem side, I categorize these 4 issues as under the category of the promise of health reform is not being realized as it needs to be for people with disabilities. 1 issue on benefits and 3 on affordability. First, on the benefit side, we really urge that the Minnesota Care program, which is transitioning over to qualify as our basic health plan, include services needed by people who have disabilities but can avoid the total and permanent disability path of Social Security. We think this is such a promise in health care reform, but we won't reach it unless the benefits are there to allow people to avoid that. And this is especially important for young people who have gone to school, are ready to work, and the first thing they have to do is go to Social Security and declare themselves totally and permanently disabled, unable to work anywhere in the national economy. We defeat ourselves over and over by that policy. So I would highlight PCA services needed. I know that Gruber analysis came up with a number. It was quite low. I'm sorry I didn't have time last night to find it for you, but I think that could be added to the Minnesota Care program benefit changes, and it would make a big difference. We also had highlighted in that process non-medical or non-emergency medical transportation and services for young children with autism. The other 3 issues involve affordability. Representative Loeffler has a bill, 1039, which focused on the fact that people with disabilities and low-income seniors on medical assistance are left at their current income standard, whereas everyone else on Medicaid goes at least up to 138% of the poverty level. And this means that if people with disabilities are left at 100%, but if they have $1 more than $931, they have to spend down to 75% of the poverty level. You can't really live in the community on that. And that's what we expect people to do and we want them to do. So Representative Loeffler amended her bill. She takes just a small step toward this. We know it costs money. We know the budget situation, but we urge as this moves forward that even a small step of raising that 75% to 80%, the second year of the next biennium, be high on your to-do list. And then we've got to get the rest of the way. Also, Representative Loeffler's bill has another provision that deals with an obscure change in the ACA, which is very serious, for people with disabilities under 65 who are married. It requires states to apply a spousal impoverishment standard designed for people over 65 to those under. And let me just give you an example. We have worked with a family where the mother had a very serious stroke during the birth of her second child. Her husband, of course, was working, had 1 child already under 3, and another one, and his wife needed extensive services and support. We want that family to stay together. These new spousal impoverishment rules would hurt that, and we'll get back to a policy that I was unfortunately very familiar with early in my career, which is married people who have a catastrophic disability for one spouse end up getting divorced because it's the only way for survival, especially if they have children. Not a policy I think anyone wants to have. That provision is only requiring DHS to ask the feds to continue our current policy. And we still don't have a no-cost blessing on that one, but hopefully we will, and it can be offered Friday. And finally, I want to raise parent fees. Representative Fritz has been working hard on this, and there is a surprising absence of a needed provision in Article 1 that we think the department should have provided, and that is MA income standard for children, their parents, up to 275% of the poverty level. Our parent fee program for families over the current medical assistance limit starts charging a fee at 100% of the poverty level. Now, as part of raising to 275, we think the department should have corrected that problem and put the fee starting at 275. Again, we've been raising this issue for months, and we have not yet gotten a no-cost blessing on it, but hopefully it'll be able to be offered Friday. Thank you.
Thank you. Any questions for Ms. Henry? I don't see any, so thank you for your testimony. And next we have Julie Ring from the counties. Welcome to the committee.
Thank you. Good morning, Mr. Chair, members of the committee. My name is Julie Ring, and I'm the Health and Human Services Policy Analyst for the Association of Minnesota Counties. I want to thank all of you for being here this morning to listen to public testimony on this budget bill. When the counties were preparing for this legislative session last fall, we spent a lot of time going around the state and talking to county commissioners about what our top priorities should be across all areas of county business. You hear a lot from counties about property taxes. You hear a lot from us about roads and bridges and public safety. But we really wanted to hone our message into a list of top priorities across all of these areas for the legislature, and we did that. We came up with a list of 6 priorities for this legislature to consider, and 2 of them were within the area of health and human services. I often get told that county commissioners are more concerned with roads and bridges than they are with health and human services. But considering we devoted 1/3 of our priorities to this budget area, I hope that that shows you that that's not the case. So we had 2 priorities across all counties in the area of health and human services, and I want to thank you for including one of them in your budget. And that's the provisions of House File 869 that was brought to you by Representative Loeffler and a long list of bipartisan co-authors that would allow counties to draw down medical assistance for inpatient hospitalization of jail inmates. I'm pleased that you were able to include this because, in fact, it is cost neutral for your budget and, in fact, provides a great deal of savings to corrections. So we want to thank you for that. We think that this is good for the state, and it certainly is on our list of ways that the legislature can help to provide property tax relief to counties this year. So thank you. We had one other priority in the area of health and human services, and that was an investment in DHS technology systems. And we are pleased that you were able to include at least a portion of that funding in your contingent appropriations. Now, that's not the best case scenario, but it's better than nothing. And we had hoped, and the department had requested $29 million in investment in this area. This is something you haven't heard a lot about, probably from anybody other than me this year. But county workers use those DHS systems to do all of our eligibility work, all of our client work in communication with the department. And you've heard me say before, those systems are old. They're DOS-based. They are computer screens that young people we're hiring today don't understand and have never seen before. And without an investment in this technology, we will soon be in a position where we have a critical situation with a system failure that's going to cost us a lot more money to solve. And so I am thanking you for giving it consideration the best you could in your budget, but I want to continue to alert you to the fact that this is a key prevention item. You've heard me talk a lot about prevention in past years, so that we can stay ahead of problems when it comes to technology. And I am hopeful, and in fact just talked to department staff this morning about the status of that Reform 2020 waiver. I am hopeful that we get what we need so that we can start this process. We also want to mention 2 other upstream investments that you were able to make in this budget. I think many of you that have been around for a few years have heard me talk for just about my whole career up here about the statewide health improvement program. It's an important public health prevention program that we know will save costs in the long term, and we appreciate that you found room in your budget to support that item. We also are happy that you were able to include funding for school-linked mental health grants, which is another form of upstream prevention on the human services side of the budget. I do have one thing that we're not as happy about. And I suppose that that's the case for most of the people you're going to hear about today. We have kind of a mixed reaction to your budget. We are concerned about the cost shifts to counties that are contained in this budget. There are two of them. They are increases in cost shares for the Anoka Regional Treatment Center. The patients that are there, counties currently pay for 50% of those costs, and you're increasing it to 75%. And at the Minnesota Security Hospital, we currently pay 10%, and you're increasing that to 50%. Together, these cost shifts will total $8.2 million per biennium in new property tax burden to counties. Now, I know the governor recommended these cost shares, and we told you we didn't like them then. But when the governor recommended them, he coupled them with some investments in transition services and community services that are being developed so that we have the tools we need to move people out of these settings and into the community, which is everyone's goal. Without that investment, these are simply cost shifts to counties and another way of counties having to pay more to cover a hole in the state budget. You do recognize those transition services in your budget, but they are delayed for a year. So essentially you're asking us to front the money for a couple of years until we can develop the community alternatives we need. And so it becomes just a straight penalty to counties. So I am very happy for the property tax relief that you were able to provide related to jail inmates, but I am concerned about the new property tax burden that you've been forced to include, and I know was not something that you had necessarily hoped to include in this budget. And with that, I'm happy to answer any questions.
Any questions for Mr. Ring? Representative Liebling.
Thank you, Mr. Chair. And Ms. Ring, I think I got partially the answer to the question as you were talking, but I just wanted to know where in the spreadsheet is that money for the technology upgrade, and is it in the Reform 2020 piece?
It is. Thank you, Mr. Chair and Representative Liebling. I will admit I had to hunt for it a little bit, and my original update that I wrote yesterday said, darn, we're not getting anything. But it's in the supplemental spreadsheet at the very end. And I do have it here. It's actually the very last item in the supplemental spreadsheet. And it allows for almost $17 million if in these contingent funds. There is a small light item for the health insurance exchange within the full spreadsheet, the non-contingent items. But the request from DHS and the amount they told us that they needed to get started was $29 million. So looking for Mr. Berg, but I know you have the $17 million plus another couple million, but it is less than 29.
Representative Liebling.
So, thank you, Mr. Chair. Ms. Ring, could you just, let me just say, I went in Olmsted County. Under much urging, I did visit over the interim. I sat with the worker for a little bit and saw what they have to do, and it is impressive, I have to say, how archaic that whole system is. And I am totally with you. We absolutely need to upgrade that system, and we'll probably save a lot of costs in the long run because the amount of personnel time that's involved in trying to use this old system is just astounding. And I'm in awe of the people that are doing that work. And it's amazing we don't have more error than we do under that old system. But I'm just trying to understand, is this money then that goes to DHS who does the upgrades, or exactly how does this work? I was surprised that it wasn't sort of part of the overall upgrade of technology in the first place, because as you know, we're spending a lot of money to upgrade technology right now to do all of these things seamlessly. So can you just give us a little more understanding of how that all is supposed to work?
Ms. Ring.
Sure. Mr. Chair and Representative Liebling, thank you for the question, and thank you for taking the time during your legislative break to sit down with one of your county workers. I know they really appreciated that. So there is a lot of money being invested in technology right now for the health insurance exchange, and that's going to be an important way of making the eligibility system for health care programs work more efficiently, and that will be a benefit to us as it is to clients and the department. What we are concerned about are the other social services systems for other programs, food support, the wide variety of other programs are still running on the old DOS-based platform. And for a county worker, when a person comes into our office and sits down to talk about what they need, most often, if a person qualifies for a healthcare program, they qualify for some of these other supports as well. And so having one system be upgraded has promise for making us more efficient, but these other systems lagging behind means, in fact, we're going to be doing multiple data entry right now, but we're going to be doing it in this variety of platforms. And so DHS separated the health exchange, well, DHS and the governor have a specific focus on the health exchange, and this upgrade of the other systems was sort of an add-on. And it's a good time for the add-on because, in fact, they can draw down federal money to upgrade these other systems at the same time as they upgrade the exchange and upgrade them to the same platform, et cetera, as the exchange. But it is considered a separate item in their budget and was not included in the larger package.
So,
Representative Liebling.
thank you, Mr. Chair, and I won't take too much more time on this. But so is this drawing down federal money? If we do this specific upgrade to the county systems draws down federal money, is it a 50-50 match, or what is it?
Thank you, Mr. Chair. Representative Liebling, I did try to confirm this with DHS because I don't like to get numbers wrong when I'm testifying on the record, but it's not quite 100%. My understanding is with the $29 million investment, DHS believed they could draw down 21 additional million from the federal government. So it's a pretty good match in terms of being able to access the federal money. And that is time limited. And I don't have the exact dates as to when that option expires, but I know that it's short-term in conjunction with the rest of these Affordable Care Act upgrades. And I realize while I'm talking that I forgot to answer the second part of your question. So very briefly, what I will say is this funding would stay at DHS. It is for their work to upgrade their systems, which we feel benefits us. We have lots of needs, and I've talked to you about our computer technology needs in the past as well. But we feel that without the solid platform and foundation, we have to have that first. But certainly we have our own system needs as well. But those are not part of this request.
Representative Abler.
Well, thanks, and I'll be brief. I just, on this 75%, 50% thing, understanding the leanness of the budget and all that, some of these savings proposals are going to be hard to have you get rid of. There's a perception by me, at least, that there's some counties that are very innovative in placing people to these discharge-ready patients or clients, and some that are laggards. And so I'll just advise you to find a way to move the laggards along, and maybe you don't need the pressure, but sometimes only pressure that moves lagging counties is economic. And so I just want to caution you as this goes forward that it might not go away. So, and take that back to your group. Thank you.
And Mr. Ring, you did not complain about the fact that the MA expansion is going to cost counties about $10 million in the short term to hire more people to do all the enrollment problems that we're going to have.
Thank you, Mr. Chair. I did try to focus my comments, but you do raise our other concern, and that is we do have concerns about the immediate cost of the expansion and exchange on county workers. So thank you for allowing me to put that on the record as well.
Representative Loeffler.
Thank you, Mr. Chair. And just briefly, whenever the federal government gets into budget cutting, what it does is it ups the amount that it expects to claw back from states by finding errors, higher error rates, and it increases the penalties. And so really we as a state budget actually get at risk too when we don't have good systems that help people keep their accuracy rate up. And if we have, and that's one of the things that I think is a promise of if we could somehow squeeze this in the conference committee or somewhere else, is I think we could probably get the 90% federal match on the linkage between the exchange MA eligibility system with all these other eligibility systems. And so, because right now county workers are taking data from one system and having to cross-match it to another and then go to another and then go to another. And when you try and do that, errors happen. And we're at risk when those error rates get, because the feds send out people and they literally pull charts and compare what's happened in counties across the state in doing their audit things. And if our audit exceptions get too high, the penalties can be many multiple millions of dollars. And unfortunately, that's one way that the federal budget recoups some of its budget issues, is to take back through penalties. So I'm hoping we can squeeze something sometime.
Well, thank you, Ms. Ring, for your testimony. And
Thank you.
next we have Jonathan Watson and Linda Sandvik. Welcome to the committee.
Thank you. Mr. Chairman, members of the committee, my name is Linda Sandvig. I'm here on behalf of the Safety Net Coalition. The Minnesota Safety Net Coalition is comprised of community clinics, community mental health center, dental clinics, safety net hospitals, public health and home care agencies, and outreach and enrollment agencies. And their prime mission is serving people on public programs and those that are uninsured. And also people that face barriers dealing with their income, language, race, ethnicity, or disability. First of all, under the difficult targets that the chairman had, we'd like to thank him for a number of the things that are included in this omnibus bill. First of all, for safety net providers, obviously, as far as serving a disproportionate number of the uninsured, expansion and health care coverage is a priority. And so looking at expanding the Minnesota Care as the basic health plan and improving those benefits is something that we really thank you for. We also look as far as looking at some of our safety net hospitals and including funding for Merck and also extending the emergency medical assistance coverage for both cancer and dialysis as important. Also for some of our dental clinics, expanding adult dental benefits and also some of the mental health initiatives for community mental health clinics. We also would like to thank you as far as some of the specific subsidy programs for safety net providers, that there were no cuts in those areas too. But as everybody else, we've got the things that we'd like you to consider as far as things that are obstacles for safety net providers. A number of those things were included in Representative Moran's Bill 1345. And basically, part of our message for this session has been that even though we're looking at expanding MA coverage, the basic health plan, that there's still going to be about 201 people as far as the Gruber assessment that says that there will be people that are uninsured. And we also see that in looking at the expansion, that safety net providers will be providers of choice because of the services that we provide. This held true in Massachusetts. Even though coverage increased 50% for some of the community health clinics, it only increased 20%. They also found that they were serving a very complex patient with social and medical needs, and also looked at increased demand. In fact, in Massachusetts from 2006 to 2009, 31% increase in total patients for community health centers. And also saw that many of them, because of the services that they provide with translation, English, transportation, and cultural services, that their services increased. So when we talk about looking as far as reimbursement, and I think you've heard from many providers under medical assistance about low reimbursement, we also hope that you will look as far as targeting those with a disproportionate burden as far as serving both those on public programs and uninsured. And some of those providers need to be targeted. And so we've looked at some of the subsidies that we have, and at time when budget allows, we would like to see increased access for access grants. We have those in mental health, we have those in dental, community mental health centers, and also for community clinics. We would also like to see that we address that in some of the home care areas. There are some home care providers, particularly in public health, that are seeing a disproportionate number of medical assistants over Medicare, and so that produces a burden on them as far as being able to serve folks. We would also like to see a restructuring of the emergency medical assistance program, so it can help coordinate and cover as far as more community-based services rather than the most expensive services in the ER. Finally, we would like to see in the future, as we're looking as far as either payment systems or measurement, that we really look as far as looking at a risk adjustment type of thing that will look at social determinants of health care and existing outcomes. So in summary, we'd like to thank you for what you were able to do in this target, and think about kind of in the future and after 2014 the impact as far as the safety net. Thank you.
Mr. Watson. if
Right.
you could-
Mr. Chair, members of the committee, thank you very much. My name is Jonathan Watson. I'm with the Minnesota Association of Community Health Centers. I'll be extremely brief. I just have 3 points to make. I'm thankful, I'm disappointed, and I'm confused. So let's go through those real quick. I am thankful for the Community Health Center appropriation. It is about $2.3 million, and we do use these funds to partially offset the cost of care to the uninsured in the state of Minnesota, which totaled about $40 million last year for 70,000 individuals. We also use a portion of those dollars to invest back into the health centers in terms of healthcare home certification or investments into healthcare technology so we can care coordinate with our safety net provider partners. We do stand at the ready to invest additional dollars that unfortunately weren't part of this budget in terms of these monies could be into the system immediately. I talked to some health center directors who would immediately hire dentists, behavioral health workers, and additional providers. Where I am disappointed is House File 619, Representative Abler's bill that would have provided same-day reimbursement under Medicaid for medical and mental health encounters. What happens right now at a community health center, a medical provider senses a mental health issue with a patient, and the beauty about the community health center, we have all these services under one roof, so they just shuffle the patient down the hall to get that mental health services. Unfortunately, under state Medicaid policy, that second encounter is not reimbursed by the Medicaid program. So the situation is we do that as uncompensated care. We don't ask our working poor patients to come back the next day just so we can get reimbursement. So we thought this would be a more effective way in order to integrate care, which we're already doing, but it's coming at a cost for dollars that could be for the purely uninsured that we see. Where I am confused is the section or the 340B drug discount program in the budget, and it's more on my end. I need to do some more analysis of what's in the bill. I was in a stakeholder meeting about a month and a half ago at DHS, and it was my understanding that there would be no harm to federally qualified health centers or community health centers under the changes to 340B. I'm unclear in talking to some of my colleagues whether that is true or not at this point, but what that could mean is resources and revenues taken away from community health centers, and at this time it's very difficult given the increasing number of patients that we do serve on an annual basis. So that is all I have for today, and thank you for your time.
Questions, but I always refer to the Clint Eastwood movie, The Good, the Bad, and the Ugly. We have a little bit of good in this bill for particularly for kids with mental illness, but most of the rest of it is ugly. Questions? Representative Liebling.
Thank you, Mr. Chair, and Mr. Watson. I have to say that your description of your state on this, thankful, disappointed, and confused, I think that applies to all of us.
Okay.
So, we're all in this together, I guess. But my question to you, I guess, I hear you that you're not sure of the impact of the 340B thing on your operations, but I want to get a sense from you of that what you were hoping to get. I just don't have those numbers in front of me. The Abler bill obviously would have been at cost to us, and I don't know what that cost was. And then if you can estimate, I'm trying to get a sense of how these two things interact for you. If you could have one or the other, which one would it be?
Mr. Watson.
Mr. Chair, Representative Liebling, I do know the Representative Lieber's bill, the fiscal cost was $220,000 over the biennium. In terms of the 340B, I literally have not had the time to do that analysis. I suspect the impact would be greater under the 340B program, but that's just a gut reaction. I don't know because I haven't run that formula and how it interacts with our Medicaid rates at this point, and also just the policy clarity as well. So, sorry, that's not a great answer, but at least the $220,000 cost on the same day encounters.
Other questions? Representative McDonald.
Thank you, Mr. Chair. Mr. Watson, I was aware of the uncompensated care for the mental health patients and Representative Abler's Bill 619. Could you just walk us through that again, just to reiterate the fact that you send them down the hall for care, it's uncompensated, but if I heard that right and remember from years past that if they come back the next day, then care would be compensated. Could you just touch that again?
Mr. Chair, Representative McDonald, that is exactly right. A good example is talking to a community health center director, was seeing a patient on the medical side a few weeks ago, and he could sense that she was smoking again. And the issue he was on her, obviously saying, I told you to quit smoking, now you started again, actually, what's going on with this? And eventually got out of the patient that her brother committed suicide and she was depressed. So tobacco was an outlet for her. So he naturally reacted to that and said, we have mental health services right down the hall here for you. So we made that happen for that patient. Unfortunately, that second encounter was not reimbursed under the Medicaid program, even though this was a Medicaid enrollee, actually. So what occurs then is we have to dip into our funds devoted for the uninsured, of which are 70,000, 40% of our business, to treat that Medicaid enrollee. So it is a state policy that prohibits that second encounter. And you're exactly right. We could ask the patient to come back the next day so we could get that Medicaid encounter, but that's not right for the working poor patients that we serve. Their lifestyle is just as complex as everybody else's, so why make them come back, make it convenient for them? And frankly, in some instances, we never get that patient back. They disappear into the system, what have you, and may manifest themselves at an ER room or at hospitalization, which is clearly more expensive than a community health center encounter.
A lot of these, a lot of these people with have mental illnesses, and the transportation back and forth to their home is a major problem. So if you ask them to come back the next day, sometimes they just can't make it. Representative McDonald.
Yeah, thank you, Mr. Chairman. Any way to incorporate, I know you're on a tight budget, his bill, Abler's bill? I mean, look at the government. I mean, look at the way we work. Seriously. You know that, Representative Huntley. You're wise and been involved for years. Now we got a uncompensated care, and if they came back the next day, they could be. And it's a shame that you weren't. And I know you probably wanted to keep this in there. It's a shame that we weren't able to. And it seems typical of how sometimes we work around here.
The bill is not finalized yet.
No. An amendment, Representative Abler?
Representative Martin.
And I would agree. I think this is, a common sense cost-saving thing. And I would say, while there may be a fiscal note, often we aren't able to recoup the savings because it's in a different bucket. And as we talked about this when the bill was being heard, there are cost savings to non-emergency medical transportation because we have to pay, MA has to cover the cost of transportation for the second trip as well as the first one. So I do think there is some cost savings here. We just aren't ever allowed to count that as we do our work. So I am hoping at some point along the line, Representative Huntley will keep this in the back of his head, and if we can't get it on right now due to the fiscal note, there's always negotiations later in the process, and hopefully we'll be able to work this in.
Representative Liebling.
Thanks, Mr. Chair. And, just to say, first of all, everybody knows this is a huge, complicated budget, and the whole purpose of having this kind of testimony is to help us perhaps reprioritize and figure out if we miss stuff. So, which it doesn't mean we'll be able to fix everything we'd like to, but it's, that's why we're doing this. And I know when you visited me earlier in the session, it makes total sense what you're asking to do there. But in order to just sort of give us the complete picture here, since we're rediscussing it, could you also sort of explain to us, if you know, why that policy was instituted in the first place? Because I know it wasn't irrational. It may not have worked out well, but can you just sort of share that other side?
Mr. Chair, Representative Liebling, I do know that 26 other states allow these same-day encounters to occur. And secondarily, I don't want to speak for the department on their policy decisions. I suspect it was a theme of theirs to make sure there's pieces in place to prevent fraud in terms of double billing and those sorts of things. I believe that is probably what they were thinking when they decided to do it this way. We are paid slightly differently. We get a medical and a dental rate, and we can do the medical dental on the same day, but we can't do the medical mental health on the same day because it is the exact same dollar amount. So there may be some systems and some fraud and policy issues that the department was citing at that time.
Right. And Mr. Chair.
Representative Liebling.
Yeah, thank you. And I'm not saying that I, support that policy. Just that I think it's important for us to sort of know what the concern is on the other side and why that was put there. And of course, it wasn't aimed at your organization. It's just a general Medicaid policy. And so just as we consider system changes like that, I think it's important to consider the whole potential impact. But of course, we've seen the policy play out, and whether that's a big area for fraud, I don't know.
And Mr. Chair, Representative Liebling, just to address that real quick, there are 17 federally qualified health centers that have this policy, as well as roughly 60 rural health clinics that are reimbursed under this mechanism. So that would be your universe that's affected by this policy, just to clarify.
Thank you for your testimony, and we'll move on to Bridget Sillander. And folks, we're going to have to move pretty quickly, though, because we've only gone through 4 groups, about 45 minutes. Representative Grunet.
Oh, thank you, Mr. Chair. Yeah, I would just say, ask the committee and chair to give consideration to reducing the amount of funding for the exchange. I mean, we've got one of the highest priced exchanges in the whole nation. And I think we're paying a Cadillac price for that, and it's unnecessary. And here we have a situation where we could actually meet vulnerable people's needs by coming up with a more cost-effective exchange. And the easiest way to do that is reduce their funding and say, you know what, we're going to drop you 25% and give it to meet the needs of people rather than grow government bureaucracy. Just a suggestion and food for thought. Thank you.
Okay, is Ms. Sillander here? I don't see her, so we're going to go to Matt Schaefer is next.
Oh, here she goes.
Oh, she is here. Okay. Yeah, and members, just remember the amendments are due on Thursday. Welcome to the committee.
Thank you so much, Mr. Chair and committee members, for the opportunity to offer my testimony. I'm a personal care assistant. I've been doing this work since 1997, and I'm also the president of the Direct Support Professional Association of Minnesota. And our organization seeks to improve the quality of human services provided to persons with disabilities and older persons by strengthening the direct support professional workforce. So direct support professional is a broad umbrella term that encompasses personal care assistants. So I would like to thank the committee. I believe there is actually an increase in the budget for personal care assistants. We certainly appreciate the investment in community-based services for people with disabilities and elders. Our organization did send out a legislative letter outlining some position statements. We support the addition of some on-site training hours also for direct support professionals. This provides an opportunity for experienced workers to train in new workers. And we also support efforts to make sure that health insurance is affordable and accessible to direct support professionals. The lack of health insurance causes dedicated people to leave the field out of necessity to care for their personal and family needs. So this is a relatively short testimony considering there's so much wonderful support. We are so appreciative and grateful. And thank you for your leadership, Representative Huntley. I know you're working as a PCA. Thank you, committee. Are there any questions?
Any questions? I don't see any, so thank you very much for your testimony.
Thank you.
And next is Matt Schaefer.
Thank you, Mr. Chair. For the record, my name is Matt Schaefer. I am with the American Cancer Society Cancer Action Network. I would like to begin by echoing Ms. Sandvik and Mr. Watson's comments in thanking the committee for your efforts to expand the Minnesota Care Program, as well as the administration's efforts to pursue federal funding for the basic health plan. As folks in the committee may be aware, one of the reasons that Senator Cantwell from Washington had actually ensured this was a part of the Affordable Care Act was because her home state of Washington was a little further ahead in trying to provide coverage options to the the population that's enrolled in Minnesota Care over in their state, and obviously their situation is very similar to ours. And so we do appreciate the efforts to pursue those federal funds to help make a good program better. One shortfall that has really hit our constituency within current Minnesota Care Forum is that inpatient hospital cap that can have a real devastating impact on somebody undergoing cancer treatment if they're enrolled under Minnesota Care. So we see this as an opportunity to address that. I will also say, obviously, there's a lot of work ahead, and Ms. Henry outlined a couple of places where there's some more work ahead, and I know that that'll continue. I'd also like to thank you for including funding, for adopting the governor's recommendation to fund the SAGE program, the breast and cervical cancer screening program. This is a program that our organization also puts donor dollars toward making sure it's successful in the form of in-kind contributions, aiding with screening drives and trying to make sure that those women who are uninsured or underinsured can receive those preventive cancer screenings they need, and then opportunities where we can get them enrolled in some sort of program, whether it's public or private, we can assist them with that. Because of that collaboration with the private and public sector, Minnesota reaches one of the highest percentages of that eligible population in the country, and also that's also a good testimonial to the FQHCs, who Mr. Watson represents. They're a great partner in this, and so as long as we can keep our public friends at the table, we can continue doing good things. Lastly, I want to express our support of the funding for SHIP, Statewide Health Improvement Program. We always look at SHIP as a program that embodies the art of thinking ahead. When you look at the disease of cancer, 1/3 of every cancer diagnosis is tobacco-related. 1/3 of every cancer diagnosis is obesity-related. So if we just implemented what we knew, we could get rid of 2/3 of every cancer diagnosis in this country. And SHIP is a step in that direction. Now, Representative Abler had a tough job 2 years ago in putting together a very difficult budget, but this was a program he still was able to include some funding for, and we remain appreciative of that. Moving forward, we do think that this is a good opportunity to restore it to a statewide program, because there are still some counties that don't have a presence at this point, and this is an opportunity to move forward. The original funding level was $47 million, and we sure wouldn't mind seeing that go up a little bit. But in any case, we do want to thank you, and thank you for your time.
Questions for Mr. Schaefer? I don't see any, so thank you very much for your testimony. And next we're going to Diane Raff. Welcome to the committee.
Mr. Chair, members of the committee, thank you very much for having us here. I'm Diane Raff. I'm the director of the Living at Home Network. We're the largest network and organization of community-based providers of senior services in the state. And we represent 39 programs. We also are partners with other organizations. You may be familiar with Faith in Action programs. They have about another 20 programs. And then there are others that are not affiliated with either group. And all of us are supporting the proposal that came through as part of the Reform 2020. It's the Article 2, Section 28, Subdivision 1A, Home and Community-Based Services for Older Adults. And I want to thank you for your years of support. We have in Minnesota a really unique and vital, cost-saving, community-based service providing system. It's very community based, and I think many of you probably are aware there are some in-depth information sheets there that can go around whenever someone has the opportunity. Just wanted to make sure that as you come to this point of finalizing the budget, and you may be looking for places that you can take a little money here and there, want to make sure that you understand that the $1.5 million that is allocated for a slight expansion of this is not a place that you want to take money from. When you look at the annual cost for one medical assistance recipient to be in a nursing home, and you divide that out by the 1.5, it's basically 34 seniors that we keep out of a nursing home is the break-even point. And last year, our programs alone in the Living at Home Network worked with over 5,000 frail seniors. So the cost savings there is obvious, and as we prepare for this growing tide of seniors, this is a very small investment for getting ahead of that, getting ahead of the growing costs. And so we just want to make sure that, when things push come to shove in these last little bits, and you look at that really pretty small amount, that you don't go, oh, well, because it will end up costing you a lot more in the end if it disappears. Thank you.
Questions for Ms. Rapp? I don't see any, so thank you very much for your testimony. Next is Alice Holbert. Okay, we'll come back to her later. Ron Elwood. Welcome to the committee.
Thank you, Mr. Chair. Ron Elwood with Legal Aid. I'm here today to support and thank you for your consideration of including Representative Halverson's House File 1443 in the bill. This is Legal Aid is working with the Citizens League on this one, and this is a family independence demonstration project. And the bill that we would ask for inclusion would simply say that the small stipends, very modest payments that the Citizens League will make to this demonstration project families, they're groups of families trying to move towards financial independence, would not be counted towards income for purposes of child care support and things like that. So the idea is that we don't want to have our policies at cross purposes where we're trying to build assets, get people moving into financial stability, and then at the same time punish them for their success. So we do appreciate the possible inclusion, and want to let you know we are waiting for a fiscal note. We don't expect there to be any cost to this, but we're still waiting for DHS, and there would be a slight amendment if you're willing to put it in on Friday, which we're working on. Thank you so much.
Thank you. Questions for Mr. Elwood? Don't see any, so thank you very much. Next is either Lyndon Gaboy or Deb Konechny. Welcome to the committee.
Hi, my name is Lyndon Galboy. I'm with the Welfare Rights Committee. We're here to say, first, we're glad that the family cap is here for possible inclusion in the Omnibus bill. But we're mainly here to talk about something that is not in this proposal and that we feel should be in this proposal. In fact, should have been in every budget proposal for the last 27 years. And that is an increase in the MFIP cash grants. 70,000 people in Minnesota are receiving public assistance through the Minnesota Family Investment Plan, or MFIP. Right now, these 70,000 children are living in what is termed extreme poverty. Increasing the grants could change the situation for these 70,000 Minnesota children immediately. Cash grants for children and their caregivers in the Minnesota Family Investment Plan have not been increased since 1986. That's 27 years ago. Meanwhile, the cost of living has more than doubled since 1986. In 1986, a family of two received $437 per month in cash to live on, and today that family of two still receives $437. Remember, this is the total amount that has to pay for rent, utility bills, phone, children's school costs, transportation costs, clothes, hygiene, household supplies, laundry costs, any additional food costs when the food stamps run out, and if a family's lucky enough to have a car, gas insurance and car repairs. It's impossible. Some of you know that many senators and representatives agreed to try to live for 1 week on the equivalent of what an MFIP family lives on. They quickly saw that it was absolutely impossible. The simple result of these grant levels is homelessness and hunger, and it's got to change. The current grant levels put families at 70% below the federal poverty level, what is officially termed extreme poverty. Even the Department of Human Services stated that extreme poverty has the most adverse effect on children's health and well-being. Even if the MFIP cash grants were doubled, families would still be 30% below the federal poverty level. Getting to this budget bill, we know that the targets for HHS are terrible. But the fact is that the money is there to increase the welfare grants. Every year, Minnesota gets an annual block grant from the federal government for welfare, the TANF grant. According to figures from the DHS, in 2012, only 27% of the TANF block grant went to cash grants for Minnesota families in poverty. Over the past decade, hundreds of millions, maybe even billions, have been taken from Minnesota's TANF block grant to supplant general fund spending for other programs. In other words, this means that 73% of the federal dollars meant for poor families, meant for welfare, went to other things. As you can see in one of the sheets we're spreading around, in 2012, only $73 million of the $263 million went directly to cash grants. The rest, and also $71 million, was transferred out of TANF to other funds. In 2013, $88 million is planning to be transferred to other funds since supplant general fund spending. I'll list what some of these areas are. $11 million is spent on visiting nurses. $100 million, $30 million more than goes to cash grants for poor families is spent for support services that the DHS lists as things like adult basic education, GED, job training, and work search and help accessing other services. It seems amazing that we would spend $30 million more on support services than on the families themselves when there has been no increase since 1986. These support services and other things I mentioned are worthy items, but why is money coming out of TANF to pay for education? Why is that money not coming out of the education department like it does for everyone else? This might not be quite so horrible if not for the fact that grants have not been increased for 27 years. Why is money coming out of TANF for work-related activities? Why is it not coming out of the department that deals with employment, the department that deals with everyone else's work-related and job search activities? This might, again, not be quite so horrible if 70,000 children weren't living in extreme poverty because the TANF money is not going for livable grants. Why are visiting nurses being paid out of TANF funds? Why isn't that being paid for by the health department like it is for everyone else? It's wrong, but again, it might not be quite so horrible if kids weren't homeless and hungry because that money that should be going to them is being used elsewhere. Why is TANF paying for working family tax credits? Why is that not being covered by the tax committee? Why is TANF money covering child care and development costs when it used to come out of the general fund? Why isn't that money being dealt with in the ECFE committee? Title 20 being paid for with TANF dollars when it used to be paid for out of the general fund. Why is that happening? Again, there's a direct connection between the rating of the federal TANF dollars and the situation where Minnesota children are living in desperate conditions. There's many reasons to raise the welfare grants. In fact, there's many financial reasons. A cost comparison, what does homelessness, hunger, health crises, domestic violence, and poverty, what do these cost the state overall? We know they cost much more than simply increasing the welfare grants. We see that education across... Yep, I have one more point. We see that education is a big priority this year in the budget. How are our kids who are living in poverty supposed to get any kind of education when they don't even have a stable roof over their head, when they don't have food, when they're in constant transition, in constant crises, and undergoing constant stress? You can put all the money that you want into education, but if kids are hungry, if kids are stressed, if kids are freaked out, they're not going to learn, and they won't have a chance. So, in conclusion, we'd like to say that after 27 years, we want this committee to take a stand. We want the whole legislature and the governor to take a stand, do the right thing, and use all of the TANF money for TANF families. We want you to claw back the TANF money that's going to other budget areas and get it back in the committee where it belongs and give it to TANF families. But even in this budget, there are millions of dollars that you can readjust to take out of those other programs and give to the people who really, 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 really need it. And end extreme poverty in Minnesota.
Questions for Ms. Gadboy? I don't see any. Representative Gruenhagen.
Oh, thank you, Mr. Chair. Just a general question. She, and I guess I didn't realize this completely. It's a learning experience here on the Health and Human Services Committee. But why she makes all these statements that the money has been rated out of the TANF funds when it's given from the federal government. Isn't that, how does that work? I mean, why is that something that was started and the federal government allows, or?
The federal government does allow that, and most of these other programs, and I understand the fact we haven't had a cash increase for 25 years, but most of the TANF money that is spent is still spent on these people, giving them other services. Okay, any other questions? I don't see any. Thank you very much for your testimony. Oh, Representative Liebling.
Thank you, Mr. Chair, and not to prolong the argument. First of all, I just want to say thank you. That was an excellent presentation, and I hope everybody heard it, because I am, I'm really with you, and I really want to do something this year. We're not going to obviously solve the whole problem this year, but we've got to do something, I feel. Representative Grunhagen, I think it's an excellent question. I think it needs to be pursued, and if Mr. Berg was here, I think he could give us a better explanation of that, because I think Representative Huntley's correct in that the money is spent basically helping a group of people. They're not all the families that are on MFIP that are getting the help, but they are low-income families that the services are being given out for. But this is a process that's been going on for many, many years, as the testifier talked to. So I just wanted to say there's more to be said on this, and I hope that Mr. Berg can, when he's here, will give us a better explanation.
Okay, thank you very much. And next is Brita Orr. From the Public Health Association. Welcome to the committee.
Thank you, Mr. Chair, committee members. My name is Britta Orr, and I'm the Executive Director for the local Public Health Association, which represents city, county, and tribal public health departments across the state. LPHA is very pleased with many aspects of this budget bill. We're glad to see efforts to bolster core public health infrastructure through MDH, particularly the regional appropriation for local health departments. The technical assistance that we receive on the local level through the Office of Performance Improvement in St. Paul, and additionally nurse consultants, preparedness coordinators, and epidemiologists at the regional level is critically important to the work that we do and to our mission locally. We're also happy to see $100,000 per year for lead surveillance at MDH, though we continue to be concerned that this is not sufficient for base level surveillance work statewide. Local units are tasked with inspecting homes where a child has been poisoned by lead, and a robust statewide lead surveillance program is necessary to ensure proper follow-up in the right places in the state. LPHA has also spoken this year in support of Healthy Homes grants and had hoped to see an allocation in the bill recognizing the critical link between health and housing. I know you heard a few testifiers on that previously. We feel it's a missed prevention opportunity that's vastly more efficient than the way we do things now to ensure we take a whole home approach. And these benefits aren't just for current occupants of homes, but also for those who reside after and those in living situations in apartments where turnover is regular. But what I do want to focus on today is LPHA's top priority in the HHS budget, the Statewide Health Improvement Program. We're very proud to partner with nearly 20 organizations in the SHIP Coalition that supports the work that's being done across the state and continue to support stable statewide funding for the program. SHIP is a top priority for LPHA and our many partners for one simple reason. We can't afford in Minnesota not to fund the SHIP program. Health plans, physicians, advocacy organizations, and business representatives that are a part of this coalition agree. The work of SHIP in Minnesota cross-cuts sectors, and you're going to hear shortly a business perspective on SHIP and a school-based perspective on SHIP regarding the impact that it's having on health and productivity and connectedness in communities all across the state. We had a lot more people willing to talk about SHIP, and I think that's a testament to its successes. And so we've circulated a number of letters from other points of view stressing why SHIP is indispensable at the local level. Even with inconsistent funding and a change in scope after the scale back, SHIP is doing really tangible things in our communities. Whether it's the cities of Bloomington, Edina, and Richfield having 40% of their concession choices healthier, but also increasing their profits by 10%, which is a win-win. Whether it's in-home daycare programs in Brown County showing that there's new health and physical activity curriculum is engaging students in 20% more activity. Whether it's businesses like Rigid Hitch in Burnsville seeing a no-cost tobacco cessation pilot reduce smoking by 20%. We know that there are strong results from this program and that these examples are just the tip of the iceberg. SHIP is a roadmap to a healthier Minnesota, and it's really changing the way that we think about health in this state from the ground up. It's kept us on a nation-leading path to turn the tide of skyrocketing healthcare costs. And we know that reducing our collective weight in this state by just 5% by 2020 would save us $11 billion. So we are very thankful that there is an appropriation in the budget for SHIP. We think that if given more time, SHIP is really the best vehicle for the cost savings I just mentioned. Coalition partners would definitely approve of investing even more in SHIP. We know that it was $47 million originally, and we know that the original funding amount, if given time, stable funding amount, could really up the bar on what we've done so far and get consistent research and results over time. So thank you for your continued support of SHIP, and thank you for your time. I'll stand for any questions.
Ms. Orr, if you could get me just a copy of those numbers you gave on the results in the various communities, I'd appreciate that.
Mr. Chair, committee members, there are a number, there's actually a great report out by the State Health Department that I'm happy to share with everyone that really signifies the reach of the program, but there are some very specific examples where we have, like those that I just mentioned, so I'm happy to get those to you.
Other questions? I don't see any, so thank you for your testimony. And next is Tom Mason. Welcome to the committee.
Thank you, Mr. Chair, members of the committee. My name is Tom Mason. I'm president of the Alliance for a Healthier Minnesota. We're a group of employers who promote business or who promote wellness and prevention and improved behavior, healthy behavior on behalf of employees as a way to decrease the cost of health, both in terms of insurance cost and lost productivity. Over the last 3 years, we've seen a dramatic increase in the awareness of employers on behalf of worksite wellness, particularly among small businesses. Enterprise Minnesota is an organization that will release a poll next year that shows that concerns about health care are the number one concern of employees, manufacturers across the state for the 5th year in a row. I conducted 19 focus groups related to this poll, and I will tell you that that number does not adequately represent the depth of concern that employers, owners, and managers think about health care. We did a poll with the Alliance for a Healthier Minnesota did a poll funded by CDC last year in which we did a national poll through Public Opinion Strategies in Washington, D.C., and we polled 6 states, Florida, Missouri, Arizona, Hawaii, Wisconsin, and Minnesota was the 3rd. And there were 3 really important, I think, relevant things about wellness that highlight the value of SHIP, which I should have mentioned earlier. I'm here to support SHIP. The 81% of the employers in Minnesota understand the value of worksite wellness as a way to reduce costs of health care. That's a remarkable increase over the last few years. 81% see the value of it. They also understand the value of community collaborations on behalf of health care. You know, my founding members are all big companies, Medtronic and Target and General Mills. But the companies that really need this, 65%, almost 65%, of the employers in Minnesota have 100 or fewer employees. They don't have the wherewithal of the big companies to address these things. They look toward, they don't even have HR departments in most cases. They look toward community collaboration. 70% said that they would participate in a community collaboration based on this. And I think the most surprising number to me of all in this particular Minnesota-based poll was that 70% of the employers that we surveyed said that they thought that that public health should be funded with at least as much or more funding to help enable these collaborations. These are businesses that we're talking about. They're not the usual public advocates for public health that we would think about. We think that SHIP is that local connector in terms of public health. SHIP is a great program that will connect for these employers, will connect public health and employers and employee organizations and other health groups and insurers and providers all in one group, which they have a track record of having done, and for everybody's benefit. We believe that SHIP and the SHIP, we appreciate with gratitude that you've included the SHIP funding in this. We think the employee, the worksite wellness aspects of it are a very wise and useful investment of state funds that will provide ultimately a market-based solution to health concerns. We're big advocates, and I appreciate the time that you've given me to talk today. Thank you.
Thank you, Mr. Watson. Questions? No? Okay.
Thanks.
Any other questions? Thank you very much for your testimony, and something that I'm really interested in. And again, it's because all the major corporations do this, but it's the small businesses that can't afford to do it. Next is Barbara Matura. Welcome to the committee.
Thank you. Good morning, Mr. Chair and committee members. Thank you for allowing me the opportunity to tell a story of how SHIP has changed the culture and health of our school environment at Hopkins Public Schools. The statewide health improvement program in schools is at the heart of prevention and public reform. Through the SHIP funding that Hopkins Public Schools has received, we've been able to positively influence our youth, our public school workforce, our parents, and our community. SHIP funding has done great things in our schools, and we've only just begun. More specifically, with our SHIP funds, we've been able to establish a position and the activities of a nutrition and wellness coordinator that has one single focus: to motivate and inspire students, teachers, parents, and administrators to improve the school health environment. Through this position, we have accomplished the following. We've significantly increased our farm-to-school efforts. We've had gardens at 7 of our 9 schools. We've purchased thousands of dollars of local foods, from produce to grains to locally raised chicken and beef. We've even been able to bring the farm to the school to help ignite that spark of interest and create excitement about fresh foods in our students. We've worked on recipe creation, which in turn has significantly and effectively increased our scratch cooking efforts. This has transformed previously picky eaters into now adventurous eaters who are willing to try new foods. We've conducted numerous nutrition education units and worked with our school building student wellness groups to involve the students in creating their own healthy school environment. We've worked with teachers and administration to address food in the classroom that's typically used for rewards and school celebrations. Many of our schools now limit these foods to only those that are energizing and healthy foods that contribute to a student's health and performance. We've implemented active classrooms and active recess. We now have teachers who regularly allow their students to take an active break from their rigorous classroom work to allow for more oxygen flow to their brain and to refresh their lymphatic systems. This in turn helps to improve student concentration and behaviors. We've been able to apply for grants that have helped fund and expand our efforts. We've successfully applied for breakfast grants, farm-to-school grants, and USDA fresh fruit and vegetable grants. All of these help to increase our students' knowledge of nutrition and access to the right foods. All of these efforts are critically important in schools. As you may know, children's behavior, intelligence, and performance are significantly affected by the quantity and quality of what they eat, as well as the quality of their learning environment. Underlying health problems, even those that seem minor, affect children's overall development, cognitively, emotionally, and physically. The food they eat today becomes the cells that make up their brains, their heart muscle, their lungs, and their skin tomorrow. This funding has been absolutely key in helping us make sustainable changes in our school and our community environment. But almost better than that is that this work is being replicated over and over again in school communities throughout our state. As with all SHIP schools, we freely share our successes, our failures, and our resources with other districts by participating in presentations, conducting school kitchen tours, and participating on statewide committees. So this funding has touched many students throughout the state of Minnesota. In the end, the good news is that we have been able to change what our students eat. We have been successful in motivating and inspiring our students, teachers, parents, and administrators, and we have been improving the school health environment. Our SHIP funding has helped to fuel our work, just as our work has helped to fuel student health and academic achievement. Please continue to support the Minnesota Statewide Health Improvement Program in your budget negotiations. Thank you.
Thank you very much. Questions? Jeannie, so thank you again. And next we have Chris Bell from the American Council of the Blind. Welcome to the committee, Mr. Bell.
Okay, thank you. All right, good morning, Mr. Chairman and members of the committee. My name is Chris Bell, and I am here on behalf of the American Council of the Blind of Minnesota. We are a 501c3 nonprofit that helps blind and low vision people improve the quality of their lives throughout the state. I'm here to oppose the cuts to the targets in HHS of approximately $150 million that were made from the governor's budget. And I'm going to give you another fact. You've heard many from previous testifiers, but I'm going to give you another fact, which is a reason why such cuts are not appropriate. I recently read from the American Community Survey, which is done by the Census Bureau, that baby boomers are not, in fact, saving to pay for their retirement. In fact, 60% of baby boomers have less than $25,000 in savings for retirement, and 30% have less than $1,000 in savings. Now think about that. What that says to me pretty clearly is that for our generation, the long-term care that we are going to need when we get to be 85 and older is going to have to be funded by medical assistance. And clearly, that's not something that we can afford to deal with, on a short-term basis. One of the problems we have, obviously, in our budgeting process is that we budget on these 2-year cycles. And since we have to make sure that we have a budget that is, not out of balance, we focus on the 2 years, and we lose focus on the longer term. I think you've heard today from the testifier of the Welfare Rights Organization regarding TANF and many others that we need to spend money in order to save money. And our costs are going to escalate. By 2030, all the baby boomers will be over 65, and 10,000 of us every day reach the age of 65. So if we aren't willing to make the investment to spend money in order to save money, we will be incredibly behind the 8 ball as the future approaches. And that's all I have to say, Mr. Chairman. Thank you.
Thank you, Mr. Bell. Are there questions for Mr. Bell? I don't see any, and we're, thank you, Mr. Bell.
Thank you very much.
And we're just about out of time, but what I would like to know is there's somebody that's signed up to testify that's driven a long way and would like to talk now and not have to come back this evening. And
over here.
There's one here. Okay.
May I?
Yeah. And please give your name and for the record, and try to keep it under 3 minutes.
I am off of work today, and it's going to be hard for me to come back. So I am taking the place of Sonia Vaughn. Sonia Vaughn's not here today, so if I may speak in her place. My name is Lori Anderson, and I work at Serenity Senior Care in White Bear Lake. So do I have your permission to proceed?
Yes, go ahead.
Okay. Thank you, Mr. Chair, and thank you, everybody, for putting up with this. As I said before, my name is Lori Anderson. I'm a nursing assistant. I have been working for one for 34 years. I'm not a great orator or professional speaker, but I will speak to you with simple honesty and from the heart. I know many of you think of money and budgets when you think of long-term care industry, and rightly so. It's your job. But when I think of nursing homes, I think of the many faces of the people I have known and come to love through the years. They are the faces of people who have loved. They were loved in their lifetime, people with dreams, ambitions. They raised families, served their country, and rocked their babies to sleep. They are our mothers, our fathers, our grandparents, or someone's child. They are people like you and I. Many of them are elderly, many are frail, and have ailments. Some can't speak. They're all vulnerable, but not less valuable. I have found that if you spend time with them, you will always find something in common, a common thread of humanity, and that's my job, because we all deserve and need to feel loved and worthwhile. Budgets have a price, but that price should not be the quality of life and human dignity. I am proud of what I do and where I work, but I am not proud of what we have let happen to my industry. We have high standards and expectations, and rightly so, but we don't support those high standards with the dollars needed to staff properly. Nursing assistants on an average have 12 to 14 residents to take care of. When we are finally able to recruit new employees, they are often underqualified or they don't stay. We have not seen any sort of decent wage increase in years. The residents we get have much more complex medical problems, and the stress is through the roof. Your best efforts and hardest work just isn't good enough anymore. Many staff are leaving to go work in hospitals where they can make $4 an hour more and have less patients to take care of. And then you have the stress of just trying to make ends meet on a paltry wage. Working in a nursing home has become like working in a sweatshop of humanity. Every day I go to work, I feel like I play that old game, Beat the Clock, and I'm on Survivor. Get report, beat the clock. Get vital signs, beat the clock. Toilet, dress, and groom your residents, beat the clock. Pick up rooms, pass water jugs, beat the clock. Reposition them, beat the clock. Feed people, beat the clock. Give a shower, beat the clock. Well, you just get the idea. And through it all, what's going to get you voted off the island? Stress, injury, human error. You hope to survive the day to play it all again tomorrow. To anyone who doesn't think long-term care is in desperate need of a rate increase, I would like to challenge you to go work in a nursing home and try to live on our wages. You get what you pay for, and it's really quite simple. Better funding equals better care. I would like to end this with 3 things for you to keep in mind. At the end of my workday, I take the time to go to each of my residents and thank them for the time spent with them, for it is a privilege to take care of them, and it's also your privilege. The second thing I'd like you to remember is that life is what you make it, and so the saying goes, well, their life is what you make it also. What value are you going to place on that? And last but not least, today the future of nursing homes is in your hands, but in the blink of an eye, your life can change drastically, and tomorrow your future will be in my hands. Please do the right thing. Please do the moral thing. Please become our champions and grant nursing homes a rate increase. Thank you.
Thank you, Ms. Anderson. Are there any questions? Representative Fritz and then Representative Liebling.
Well, Ms. Anderson, thank you. You actually, I am having a hard time because you bring tears to my eyes. I understand how hard you work. I want to thank you for your hard work and your dedication.
Thank you.
And we do understand the importance of this, and we are continuing to work at trying to find a decent amount of money this session to put towards the work that you do. But I thank you for your testimony. I feel the pain. I've lived the pain, and I think we all feel the pain. Thank you.
Thank you.
Yeah, thank you, Mr. Chair and Ms. Anderson. Representative Fritz really said what I wanted to say. Thank you so much. That was really incredible, and thank you for the hard work that you do.
I want to thank you all for your hard work, too, and for your time to allow me to sneak in here and give testimony. So thank you very much.
Representative Gruenhagen.
Just real quick comment, too, is I just got an email while I was sitting here, actually, maybe 45 minutes ago from the head of one of my nursing homes in the district. It's a rural district. And she, based on their analysis, the money that we're giving them with the proposed rate increase versus what we're taking away from, they're actually losing money out of the deal, according to their analysis. So they're going backwards. So obviously, I favor supporting something like this versus sticking millions more into and I know this sounds like a broken record, but we're sticking millions into bureaucracy, which is worthless versus the needs of the people that are actually taking care of the vulnerable. Thank you.
Okay,
Thank you for your time.
Thank you, Ms. Anderson. And we're going to recess till 7 o'clock. And what room are we going to? Room 10. The committee is recessed.